Awesome. Okay, great. So let's pretend that conversation didn't happen. So as you might have noticed, if you haven't been before, this is a pretty informal seminar series that we run once a month on the first Wednesday at 2 p.m. UK time. And the idea is to kind of like build a community of practice around real-time analysis of infectious disease and outbreak analysis, because it's the sort of thing that you find yourself doing kind of very urgently without having necessarily the background knowledge to do it. And I think it's something that we should try and learn how to do ahead of time. Today, we're going to hear from Billy Quilty, who is a research fellow at the London School of Hygiene and Tropical Medicine in infectious disease epidemiology. He's done a lot of work on the impact of interventions such as vaccination and testing on transmission. And he worked with me starting in January 2020, but much better than me, on the response to Covid-19 within the CMID. And for that work, he received a very prestigious IMO award because of his incredibly impactful work, which we're about to hear about. And I think talk up to about 40 minutes, Billy. I don't know how long you were thinking, but any time up to 40 minutes. And then we'll have some time for some discussion and chat after that. But if you're all right, Billy, are you okay if people are kind of lost or have like a really pressing question if they put their hand up and ask in the talk? Is that okay?
Yeah, sure. As long as maybe if you jump in and tell me, because I don't always have the bar up.
Yeah, cool. So if anyone has a burning question, just put your hand up and I'll interrupt Billy and we can ask that quickly and then get on the talk. Okay, cool. Take it away, Billy.
Cool. Thanks, Sam. So yeah, thanks all for joining. So I'm going to be talking a little bit about rapid testing during the pandemic and how mathematical modeling went from, modeling was used to inform policy through the route of clinical trials in the middle there. So I'm sure I don't need much background, but as we all know, in late 2019, there was an outbreak of a severe acute respiratory disease in Wuhan in China. A month later in January, this was identified as a novel coronavirus. And being a novel agent, there wasn't much evidence for the effectiveness of therapeutic or preventative pharmaceutical interventions such as vaccines or antivirals. So in the initial stages of the outbreak, control was going to be limited to non-pharmaceutical interventions. So one of the primary ones was contact tracing, which had been used in the past for outbreaks such as SARS, HIV, Ebola. And contact tracing, the aim of it is to identify and find the contacts of cases who may already be infectious to prevent further onwards transmission to the next generation. And early in the pandemic, some modeling by our colleagues, including Sam and Joel and others, found that around 80% of contacts would need to be traced and isolated to control 80% of outbreaks and reduce R below 1. So quite a high target to achieve early in the pandemic there. In the UK, we were initially quite limited in terms of testing capacity. So there was only capacity for 1,200 PCR tests per day. Cases rose rapidly in early March 2020, and testing was actually halted as this capacity level was breached, and it was deemed not possible to control spread through testing, and testing was essentially halted on the 12th of March. The UK then went into lockdown soon after, and essentially the UK started to look at the ways out of lockdown and thought that contact tracing could be one of these things. So NHS Test and Trace was relaunched on the 28th of May, promised to carry out 100,000 tests per day, which was a high target, but actually was reached quite quickly. And at the end of the year, there was capacity for around 800,000 tests per day. How this essentially worked was that NHS Test and Trace asked people to, if they were developing any of these three symptoms, so a cough, a high temperature, or loss of taste and smell, to order a PCR test kit or go out and seek a PCR test. And they take the test and then they wait for the results, and then they'll be contacted by a team of contact tracers who would then ask for the details of close contacts from the past 2 days, and then would subsequently reach out to these contacts and ask them to isolate for 2 weeks. Initially, this was later reduced to 10 days. So contacts were just essentially placed into isolation for this period of time. Contacts weren't tested themselves unless they themselves developed symptoms, in which they'd seek out a test, and the process would then repeat. So there were a few issues with this, which limited its effectiveness. First of those being a low rate of ascertainment. So in June 2020, as we were in lockdown, only about 20% of infections were being found based on estimates of prevalence at the time by other colleagues at LSHTM. So this meant the vast majority of individuals were elsewhere, potentially infecting others and continuing transmission. So another was that if you did get a test, it took a really long time to get a test result back. So in September 2020, it was taking over 4.5 days to get a test result, and that was just the median time. Some of these were much longer. And then following that, you get tested in your new contacts. You'd be asked to report your contacts, and then these would be reached far too late. So between May and September, around 60% of close contacts were reached compared to the 80% target. And it took a long time to actually reach those. So over half of those were taking over 24 hours since the index case positive test to get traced, and 8% were taking over 3 days. So there was a long tail there. Another was that quarantine, so individuals placed in quarantine, there's individuals who are quarantined after they were contact traced. This had a really low rate of adherence, first of all. So only around 11% were fully adherent to quarantine, not leaving the house, according to surveys. But also, quarantine in itself is really non-specific. So this is all contacts. And at the time, the estimates of the secondary attack rate, so the proportion of contacts of cases who were actually infected, was only around 6%. So the vast majority of these were not infected at all. So you're isolating a lot of people who could, plausibly be out work, for example. And then there was also this issue of a payment for individuals who were asked to isolate. And out of those who did apply for these £500 isolation payments, only around 7 out of 10 applicants were rejected for that. So a lot of people were told to isolate, couldn't because they had to work, and then weren't able to get payments to support them during their isolation. So how could contact tracing be improved? So one issue was with tests. So up until now, tests have been conducted with PCR, which were considered the gold standard of diagnostics. These are considered the gold standard because they can detect very small quantities of RNA. They have high sensitivity and specificity, but they require lab processing, which is really slow and expensive. In mid to late 2020, there was a push to assess different kinds of tests, one of which being lateral flow tests. So lots of money was put into this. They work by detecting viral antigen rather than RNA. You can, any individual can use them to test themselves, and they give a result really quickly. So result in 5 to 30 minutes. And they're really cheap. So you could use lots of tests for the cost of one PCR test. So some evaluations were set up to look at the effectiveness of lateral flow tests at PHE, one between PHE and Oxford, and also there was this Liverpool mass testing trial. And these two found lowish sensitivity. Though they also noted that the sensitivity varied depending on an individual's viral load. So this increased when individuals had a higher viral load and when carried out by trained professionals. Lower sensitivity for individuals, members of the public taking them as well. And in Liverpool, they found something similar, so a low sensitivity overall, but then higher for high viral loads. And this led to lots of questions about lateral flow test sensitivity and specificity in the media, lots of vocal concern from some high-profile scientists. So there was talk of false positives as well as false negatives, that trials were unethical and could put individuals at risk to infection. Lots of comment pieces that were coming out around the time saying similar things, and that the tests were of low sensitivity and weren't of use. But for a infectious disease such as SARS-CoV-2, it's rather too simplistic to talk about a single value of sensitivity. We need instead to talk about the biological factors which underpin whether a test returns a positive result or not. One of which being, what is the viral load at the time of testing, as they looked at a little bit in the PHE, Oxford, and Liverpool evaluations. So for SARS-CoV-2, you essentially look at a curve like this. So individuals become infected, their viral load then increases and peaks around day 5, and then declines slowly over time. And this decline can go on for like up to 21 days or over in some cases. So there's a really long tail there. And there's a period of time where someone's viral load is high enough to infect others, which I've shaded in red here. Symptom onset at the time seemed to occur around peak viral load. And when you carry out testing, you can think of tests as having a limit of detection. So this horizontal dotted line here is talking about PCR. So this has a low limit of detection. So it can detect individuals when they have a low viral load for a long time. So as you can see, when the line is at any point over this dotted line, you could plausibly get a positive test on PCR. And then you can think of lateral flow tests as having a higher limit of detection. So here you're only going to get a positive test, but during this red section, so when someone's actually infectious. And then you need to think about when people are actually doing the test. So say someone does a lateral flow test, and you can do lots of them. You could do a couple, tests every day. So as you're incubating, you might get some negative tests there, and then a positive when your viral load increases enough. So you could get positives here, and then negatives afterwards. But then for a PCR test, you can take a test, but because of the cost of the test and the logistics involved, it's not realistic for you to take lots of tests every single day. So you could take some, for example, this person took one when they're incubating, and then they took one like a day after they had their symptom onset. And as you can see, they had a positive test after the symptom onset, but they've been infectious for a few days prior to that. So they could have been infecting others in the community there. And then they'd also be able to get a positive test after they're actually infectious. So they could be, if they only took this single test here and they became positive there, then they would enter isolation from that point and essentially be isolating unnecessarily.
Billy, could I just ask a somewhat stupid question?
Yep.
Awesome. Do you know the price difference between an LFT and a PCR test, roughly?
I don't exactly, because they weren't forthcoming with this, but I think I may have seen something on the order of it being around £160 per PCR test, I think. And then now lateral flow tests, you can buy, a pack of 10 for a pack of 5 for about £10, I think. So yeah, you can do an awful lot of lateral flow tests for the price of one PCR test.
Yeah. Okay. Cool. Thank you. That makes sense.
And just one last thing on this figure. So I'm just talking about the concept of the PCR test delay. So say you took this test a day after symptom onset, but then it takes 4 days for your test results to come back, then you could become post-infectious by the time you actually get your test result, and then isolate from that point, and it, essentially avert no extra transmission because you're no longer infectious at that point. So contact tracing was too slow and too poorly adhered to be properly effective, and places a large burden on those quarantining. when the vast majority may not be infected at all. So we asked the question of whether daily testing with contacts could reduce transmission as well as the burden of quarantine. So this could improve compliance as individuals won't have to suspend their lives for over a week. Repeated rapid tests can mean that you could identify cases quicker as they become infectious rather than days later, reducing transmission. And this could allow individuals to attend work or school if negative, and which obviously has economic benefits, as well as benefits to people's personal and mental health. So this is a bit of a schematic of the model. So we simulate index cases and secondary cases and include the delays from transmission to tracing. So an individual's infectious period or transmission potential here is shown as a dark gray bar, and the arrows indicate transmission events. The red line indicates when cases are isolated or quarantined. And we assume that index cases enter self-isolation once their symptoms develop to the point where they seek out a test. And once they seek out a test and get a positive test, this starts the contact tracing process. So then there's a delay and the contacts are eventually traced up and quarantined. And as soon as contacts are traced, they enter their own quarantine period and can no longer infect others. So sort of this second line here. Or alternatively, they start daily testing and will do a test and isolate only if that test becomes positive at any point, at which point transmission is prevented from those people. Or, they cannot be infected at all and they would be allowed to go about their daily lives. So it's a little bit more complicated than just a single line for infectiousness. We basically allow for people to have a varying viral load over the course of infection. So we based this model on a study by Stephen Kistler and colleagues at Harvard, which was a study of densely sampled actually basketball players. So they were repeatedly tested during the NBA season with PCR. And using this, we were able to create viral load trajectory curves. So for individuals, so account for the variation between individuals in their viral load over the course of infection. And from that, we can determine how likely they were to test positive by PCR or by lateral flow tests, conditional upon the viral load at the time of sampling. And we can account for correlation in the results of repeated tests, rather than assume each test was independent of the previous, because we're testing the same individuals over time and their viral load is then correlated over time. We had to make some assumptions about adherence. So we assumed that 50% of people would adhere to quarantine in the absence of symptoms or a positive test in the base case. And we assumed that 2/3 of people would adhere to isolation after developing symptoms or testing positive. And we also assumed that it would take 3 days from the index case taking a test to the tracing of contacts, whereas it would be instant for lateral flow tests. So in that base case, we found that, individuals self-isolating on symptom onset alone would prevent around 37% of transmission, and a 14-day quarantine period would prevent around 59%. PCR testing could allow for quarantine to be shortened to 7 days. So if you took a test at 7 days, then an individual could then leave quarantine. But we also looked at whether individuals could test for 5 days without quarantine, and we saw that this was likely non-inferior to a full quarantine period. So in this work, we found that getting people to self-isolate upon symptom onset had a large effect, and that quarantine could be shortened with the addition of testing. But rapid tests could open up the possibility of people testing daily to avoid quarantine completely. But what we found were essentially we need to get people to isolate as soon as possible and have adherence as high as possible. and letting people know that their case status as soon as possible with rapid tests could help in both of those regards. The major limitations here that we only consider the days of infectiousness spent in quarantine or self-isolation, and didn't link this to a change in infectivity over the course of infection. For example, if someone is at peak viral load, are they more infectious than they are, in the days prior or the days following? If you caught an individual before their peak viral load, then you would prevent potentially more transmission. So we didn't look at that in this work. We also didn't simulate onwards transmission to contacts. We just looked at the proportion of their viral load curve, which was truncated by isolation or quarantine. At the time, the performance of lateral flow test was quite uncertain, and was related to how different labs carry out PCR. They use different platforms, so that took a little while to figure out and standardize between different studies, which came later after this work. And in this work, we only looked at the effect on transmission, and we didn't look at possible false positives that could occur when testing so many people. We just looked at people who were definitely infected. So this was published in The Lancet Public Health in early 2021, because that was a preprint in 2020. This was also looked at by a few other groups at Public Health England, Warwick, and the TTI group. And the results of this were summarized at the SPI-M, so the modeling subgroup of SAGE, in a consensus statement, and then subsequently discussed at a SAGE meeting in November 2020. And the outcome of that SAGE meeting essentially was that pilot studies should be run to look at daily contact testing, and there was a few set up. So one was set up in workplaces, one set up in schools, and another in the general population, to look at the impact on transmission and behavior. So here, just looking at the trial in schools, it's actually quite unique in this regard. Not many studies were actually done during the pandemic in such in such a nice way, really. I can't think of many other cluster RCTs on COVID interventions which are actually done anywhere, really. So this is quite interesting that this actually took place during the pandemic. So this was a cluster RCT in schools. So 76 schools participated. Control schools participated. So in the control arm, these schools, individuals, so children, were just sent home for 10 days to isolate. And there were 86 intervention schools where they did a daily and lateral flow test for 7 days if they were a contact of the case. And if those tests were negative, they could stay in school until the next day when they did the next test. And the study actually found that daily contact testing was non-inferior to self-isolation for the control of transmission, with similar rates of infection between students and staff with both approaches. So 10 days isolation and daily lateral flow tests for 7 days seemed to be similar, and lateral flow tests were not worse, so they were non-inferior. There was also some qualitative assessment of this intervention. So some work found that this was acceptable, had high compliance and positivity rates were comparable to that of PCR when using lateral flow tests. People found it to be a sensible, feasible, and welcome means of avoiding unnecessary self-isolation. And the factors influencing testing, people were incentivized to take testing because they could avoid self-isolation. But there were concerns about things like test sensitivity due to the previous press coverage. And but people thought it was still useful to do so because they thought that they were able to prevent onwards transmission. So it took quite a long time actually for this to come in into actual policy. When the Omicron variant emerged in December 2021, there was some reintroduction of control measures after a lot had been dropped earlier in the summer. One of these was daily rapid testing recommended rather than quarantine for contacted cases. So finally, this policy actually came in. So this meant that individuals wouldn't have to isolate as they did previously. They would just have to take lots of tests. So LFTs weren't just used for daily contact testing. I think, as a lot of us know, that there was access to twice weekly testing for a long time throughout the pandemic. You could get 3 tests in packs of 7. People were advised to take a test twice a week if you were asymptomatic. Testing was also used to release from self-isolation if you had already tested positive and were isolating to do so, because lots of people were finding that they were testing negative, a lot. Well, they were asked to isolate for a long period of time, and there could be a period of time where you were non-infectious. So as early as the days 6 and 7 of self-isolation rather than the full 10 or 14, I can't remember. Yeah, the full 10 days as it was at the time. So we did some modeling on this, and this was also implemented as policy in the winter of 2021. Well, eventually free lateral flow tests were wrapped up on the 1st of April 2022, though you can still buy them in shops for a low fee. So since publishing our work, there have been some advances on our understanding of viral load and infectiousness. One element has been that there seems to be considerable differences in viral load and infectiousness, both between individuals and over time. And this may be implicated in super spreading events. Lateral flow tests have shown high correlation with detection of live culturable virus, which is a proxy for infectiousness. So we've been doing some work on whether lateral flow tests could prevent super spreading events by detecting individuals who have the highest viral loads before they make contacts. And I just want to pick up on this, which I saw the other day. So this study looked at lateral flow testing and PCR testing over the course of infection, and they also collected symptom onset dates from people. And they now find, so this is quite a recent study, they now find that people were developing symptoms quite early on in infection, a lot earlier than previously found in the pandemic. So now people become symptomatic, then a few days later, their viral loads increase, both looking at that with PCR and with lateral flow tests. So the authors are now hypothesizing that this is due to the buildup of immunity in the population. If you're previously exposed, you now get a symptom onset, which is the result of your immune response. But that doesn't necessarily mean that you have high levels of virus at that point in time. Your body is just, well, your immune system is acting up to turn on its defenses against infection, but that is not necessarily correlated with your viral load or infectiousness as it was before. So this means that if you develop symptoms these days, be wary and test for a few days to see if you are actually infected or not. So a single test on the day of symptom onset may not be enough anymore. So to summarize, contact tracing and case identification requires, should be really fast to isolate cases as early as possible in their infectious period. And the delays in PCR testing make this really difficult. Rapid testing could help in this, but it depends on the speed, frequency, and sensitivity of the test to detect people, and also behavioral factors such as adherence to testing, and then this could help avoid unnecessary isolation. This was demonstrated first using mathematical models, which then led to pilot studies and eventually policy in the UK. And key to this were longitudinal observational studies, randomized controlled trials, and challenge studies. These were necessary to understand the viral load kinetics and then design optimal control strategies. So I'd just like to thank you all for listening, and I'd also like to thank my collaborators and co-authors who worked on the work shown here, and all my funders as well. So thank you very much.
Wow, that was exceedingly well timed, Billy. Very impressive. If nothing else, that is inspirational to the minute.
Good.
Awesome. Shall we have some questions? I have one first, and as I'm in charge, I'll go first. Eventually policy. You kind of touched on that a bit. Could you unpack that?
As in eventually, or?
Yeah, but why eventually? Like, was it as eventually as it needed to have been? Could it have been faster? Could it have been slower? Did you feel like the policy was actually based on evidence, or they just did it anyway? That sort of thing.
So, it took about a year from the outcome of one of the first RCTs on it, and this did go up the chain. So it was quite funny because in the COVID leaks, the WhatsApp leaks that happened, there's some discussion between Matt Hancock and others about this, and it was just kind of offhand rejected, but didn't seemingly not a huge there wasn't much reason to reject it other than that it seemed like a bit of a potentially radical policy at the time, but now maybe it seems a bit more common sense. But yeah, the evidence was there. I think it could have been adopted a bit more quickly.
Okay, I have some follow-ups, but I'll let other people ask questions.
Okay, I'll go next. Okay. Thank you, Billy, for your talk. So there's some people that think we are less prepared for pandemics given our experience with COVID, especially in a lot of Western European countries in the US. You found that up to 37% of transmission could be reduced by just self-isolating upon symptom onset. Can we try harder to apply that to like seasonal influenza? Or, I mean, I think we could be doing better. If that's all it takes is just staying home when you're sick, I think we've forgotten that. And I want to know what you think we can do to make that more of a change that we keep going forward. Yeah, if you could talk about that and like why we seem to have forgotten already.
Yeah, thanks, Kelly. So I think I'd make the point that in my work, this was looking at the individual prevention of transmission events, like on the individual level, not necessarily on the population level. Like a reduction in transmission doesn't necessarily mean a reduction in overall infections, because you need to account for, well, the population susceptibility decreasing over time, and well, if there still remains a susceptible population, then those people will eventually be infected if transmission, if R is high enough, essentially. So I would make that point. I think for something that is likely to go endemic, then you can't really necessarily prevent infections, more just delay them into the future. And whether that's something that's actually beneficial needs to be looked into with respect to how much protection people have against severe outcomes over time. So for example, like if people are recently vaccinated and they have a high protection against infection, but then if their infection is delayed to the point where that protection against severe infection wanes, then that could be a negative outcome of delaying infections possibly. So yeah, I think it's a complicated question, really, and it depends a lot on a lot of factors that I didn't necessarily model here.
Got it. Okay. And then I had another quick comment about you mentioned higher viral load being associated with super spreading events. I've heard a talk recently that said timing is just as important. Can you think of a way how we would be able to untangle those, or it's quite complicated. Like being at the right place at the right time, like being infectious, like super infectious, but also singing in the choir or something.
Yeah, yeah. So I have done some work that I presented recently IDD Conf looking at this. So yeah, looking exactly that question: is it are individuals more infectious and more likely to cause super spreading events, or is it just wrong person, wrong place, wrong time? And in that, I essentially find that you do need a high number of contacts to infect a lot of people necessarily. Like that is the denominator of the infection process. So yeah, if you have someone who is at that high viral load point of their infection and has a high number of contacts, then that's where it happens really. But also I think given the data that we have on viral load progression, like most people are or do pass through a really high viral load period. Like most people probably are for at least maybe like a day capable of causing super spreading events, but most people don't have really high contact events. It's just that like combination of that. But then that's where like rapid tests could come in. So say you're just about to go to like a big party or a wedding or something and you do a test just before, then it's very likely to pick up that person if they have a high viral load, and then that can be prevented. So that's potentially something where you can use it in a nice targeted way next time.
Thank you. Sam, do you want to ask your follow-up questions while other people think more?
Yeah, so I've forgotten my follow-up question, but I have another question. So this is a bit of a tangent, but I think if I'm right, all of this modeling was simulation-based modeling, and you took inputs from other models, which were like models developed for like use interference. And like I know like Tim's model and Stephen and James's model, they were kind of like stand-based models and things. And I think your model was never kind of like fitted against data, but maybe challenged like visually against data. Do you have any thoughts about why that kind of split paradigm existed? If you think it's a good thing, if you think there are things that could have been done, so the modeling that you were kind of like taking evidence from could have been more useful to you beyond just parameter estimates, or if you think it's kind of like where we are is fine, if you don't think there's too many biases or anything.
As in, do you think
so an
that...
ideal, what I'm getting at is an ideal version of this model in my head would be the data you would fit to the data that all of these different studies had, and you would take their model and you would compose it into your simulator model, and you'd fit their data, and you'd include that all in your simulator at runtime. And then you would not only would you be able to simulate from your model, but if you needed to or wanted to, you'd be easily able to fit the data, which I think at the moment, because of like technical limitations, that's probably not. If you wanted to fit this model to data, it would be very challenging.
Yeah, I think it would. And especially as we're mostly looking at, counterfactuals, or whether people took like a test on a given day, for example. So like it would be really nice if during the human challenge studies, well, it's difficult really, because with respect to like the intervention, you're looking at like truncating someone's infectious period at a given time, and then they're gonna not go on to infect other people. But that's it's not even what's happening during a human challenge study, so you can't really fit to that. But yeah, it'd be nice for it to all to work in one framework, definitely. I think just things working in a more joined up way generally is going to be better. But yeah, I haven't really thought much about how to go about that.
Right, Samuel, do you want to go?
Yeah, it's sort of a follow-up question to what Sammy was saying. Sorry, I missed the first bit of this talk, so I apologize if you answered this already. But when you're using other studies to parameterize your simulation model, are those studies reporting at least their like credible intervals for their parameters? So I mean, like, he's not amused. Oh dear, I'm sorry, Sammy. But like, yeah, okay, so that's like pretty reasonable. I think that sounds reasonable. Like, it's hard to make joined up models in defense of like piping one model into another model. Like, I mean, you are in a sense, because like you aren't doing any data inference, although I do realize that could be a nice thing if you had the kind of study that was powered to run inference on this. And so really you're propagating the uncertainty forwards in a reasonable way. That sounds very reasonable. And I guess my second thing was like, do you have any plans to look at this in a seasonal endemic setting? Because that came up earlier, and I was going to say the same thing that you said anyway, which is that it's very different looking at this in an epidemic compared to a seasonal endemic setting. So it'd be really interesting to see what the effect was. So do you plan to do that?
Yeah, so just on the first bit about propagating uncertainty and joining things up, I think just one thing I wanted to say was something that was challenging early on was that when you're taking bits and bobs from other reported studies, they're all just like essentially like marginal, right? So say for example, you've got like the PCR positivity over the course of infection for one study, and then you've got the probability of lateral flow test given a viral load from another study, and basically just like multiplying those together, then it's really dependent on the variation in platforms, and there's no like internal validity there. So what we really were waiting for and what eventually came out was studies where they do like take a sample from one individual over time, and then they do PCR, lateral flow test, and culture on every single sample. Have like this linked up. So that was like the real benefit. Well, that eventually came through from that sort of thing, and it's not really in a model way; it's just in a kind of like actual study design way.
Yep.
Yeah, in terms of the effectiveness or assessing the effectiveness of testing in an endemic study, I haven't personally looked at it, but I'm not sure whether you'd need all this individual level stuff. Really, I think it'd probably be good to look at with potentially a SIR model. But yeah, I haven't looked at it myself with this sort of model. I think you might need something a little bit different.
Right, cool. Cheers, mate.
Thanks.
I have one more question, but I've asked a lot of questions. Does anyone else have a question?
I think you can go, Sam.
Okay. My question is, this work is very impressive, very good, conducted over a long period of time. The way this is kind of presented, it kind of feels like, the narrative was written when you were doing it, which I think for people who've done response work will know that is like not the case, or I assume it's not the case. Is there stuff that you would change about how you started doing it now that this is the kind of like end place where you are? Or do you feel like the way it was implemented initially was good, or good enough for the task at hand?
So I think I'd say at the start, just in terms of like my own personal opinion on all this stuff, I think a lot of us were really skeptical about lateral flow tests and whether they could actually be effective or not. So from the start, we definitely weren't like advocates for them. We were, essentially modeling a few things and seeing whether they'd work. And then, the value of them really came through is in the fact that you can do lots of them. You can do lots of them over time, and they give a quick result. And just like in comparison to the PCR testing, which if PCR testing happened like it did in some East Asian countries where the result comes out really quickly and lots of people get tested really easily, then PCR testing was still great. But it was just the fact that it was going pretty badly in the UK in terms of all those metrics that we turned to look at lateral flow tests, and eventually they seemed like a good idea. I think from the start, it would have been nice to do those kind of like joint paired up longitudinal sampling studies like I just mentioned, because they took well into 2021 to get anything out of. There were some, but the stuff that that Joel and yourself and Tim worked on with the crick, that sort of stuff. It would have been nice if lateral flow tests and like culture was done alongside PCR to get those kind of positivity curves. And then there was also, like, even before then, there was some PCR positivity stuff that I think came out of Vietnam, from, I think it was individuals placed in isolation after entering Vietnam, and then they were tested like pretty frequently. There was the opportunity to do that there. So I think for the next pandemic, hopefully we'd be doing those sorts of studies as soon as possible to really determine the effectiveness of lateral flow tests relative to things like infectiousness and culture, rather than having to rely on piecing together lots of disparate pieces of information from all over the shop.
Thanks, that makes sense. Good answer. Okay, if no one has any other questions, we can. Oh, other questions. Go for it.
Can I ask a really quick question, Billy? Like, thanks for that nice talk. Like I have two questions. One is really small questions, which is related to the CT value threshold in the first study. Like I think you assumed that 30 is like kind of like threshold of infectious and non-infectious. Is this a conventional value, or how did you assume that the CT value?
So this was, I can't remember exactly what it was based on, but it was a while back. But in sensitivity analysis, it wasn't actually that sensitive to what you put the threshold at, because it's quite, well, if you're testing it, frequently, then actually that doesn't make much of a difference. So you can change what that threshold is, and I don't think it's really realistic to use a threshold. Like in later work, we just, as well as having a, some kind of model, logistic model to map from CT to lateral flow test positivity, we also had one from CT to culture positivity, and you can have this kind of, people become more infectious over time rather than just like switch binary from non-infectious to infectious. So that was just something we had to do at the time because that data didn't quite exist. But in sensitivity analysis, it didn't make a huge amount of difference, but it's nice to more accurately represent that with a kind of continuous infectivity value.
Yeah, thank you. And the other question is, like, in 2021, when I talked with the Korean CDC about the implication of rapid antigen test, like our conclusion is not to use it because of the low prevalence in Korea at the time. Because like sometimes like if the specificity is not sufficient with a low prevalence, like we can have a lots of like false positive cases. Like,
Yeah,
yeah.
There was some work done by Seb, I think mostly, and there was some other metrics in the UK that essentially you could just figure out that there was the lower bound for specificity was actually still like really, really high, like much higher than than many expected. I think you do have to have like quite a low prevalence for you to to have a high proportion of false positives over true positives. So yeah, I think that this happened in the UK as well. They decided that if you were going to get a lateral flow test, then you had to do a confirmatory PCR because of like low prevalence at the time when they were making that decision. But that like time of low prevalence lasted for like a month, and then we were back in to high prevalence situations. So I think it's like, be wary about making those decisions that may in a rapidly developing situation change really quickly, and then because when you're like trying to sell these things to the public, if you're telling them one thing 1 month and tell them something else the next, then people are going to lose confidence in some way or get confused. And there needs to be some consistency there, I guess. But there certainly are times where prevalence could go low enough where that becomes a bit of a trade-off, but it would have to be really, really low indeed.
Okay. Yeah, thank you.
Caitlin?
That just made me think of a related question, which is, has anyone developed, you guys, just because you obviously think about testing and viral load all the time, has anyone developed a tool that adapts to the positivity in like some type of testing regime and then caters like the recommendation based on that? This is sort of to get around the problem of like, oh, when we're in low prevalence, we don't need to test. I thought a lot about this when I was working for a university, but I didn't do it because it was hard and required doing inference, and I mostly did like scenario projections.
Mm-hmm. We did do a bit of work looking at whether confirmatory testing was required, and yeah, I mean, essentially looking at the PPV and MPV for different prevalences. So yeah, you definitely could look at that. We didn't look at it in huge amounts of detail, but yeah, I think that's a good shout. I mean, there's the other question of whether you actually need to do like a confirmatory PCR, or whether you can just follow it up with another lateral flow test of like, a couple of days later, or use a lateral flow test of a different brand, for example, rather than have to go and use a PCR test, which takes longer. Yeah, so there's lots of different questions there, but yeah, definitely.
Right. Yeah, and that policy would depend on like the chance of it being a false positive, which would be a function of the prevalence. Yeah.
Okay, we're basically at the top of the hour, so if there are no more questions,
I have one small question. Sorry.
okay,
Just
go
to
ahead.
derail you wrapping up this. Just something you said, Billy. Different PCR from different LFT from a different brand. Does it make a difference? Do you know? Are they different?
There is some variation reported. It's difficult to know what it really comes down to, because there's things like some tell you to swab your nose, some tell you to swab your mouth, and some tell you to do both, and some ask you to wait a certain amount of time and some don't, and then some seem to use different indicators, like some give like a red line or a black line, and it also depends on how people are reading them as well. Yeah, there does seem to be some variation, and then there was lots of interest over whether it actually changed for different variants. But yeah, I think it does matter. Yeah, because in the UK we went through a few different tests, and there was definitely cases where some people would test with one and it was positive and not with the other. And I think it mostly came down to sampling site. But yeah, I think there are some other sources of variation in there. Yeah.
Okay, I think we're done now. So thank you, Billy, for your talk. We will be back next month with hopefully more than a few hours notice for the talk. We don't know who's speaking yet, but I'm sure it'll be good. So look out for messages from Sam or me, but probably me. So yes. All right. Thanks, everyone. We'll see you next month.
Thanks all.